Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content from an educational webinar titled COVID-19, Omicron Transmissibility, Severity, and Vaccine Effectiveness. During this podcast, Professor Sharon Lewin, Director of the Peter Doherty Institute for Infection and Immunity, Professor of Infectious Diseases at the University of Melbourne, Consultant Infectious Disease Physician at Alfred Hospital and Royal Melbourne Hospital, all in Melbourne, Australia, discusses transmissibility and severity of infection with the Omicron variant and vaccine effectiveness against this variant. For more information about Professor Lewin and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now, let's get started and hear what Professor Lewin has to say about the effects of the Omicron variant on treatments for COVID-19.
I'm going to start with the effects of Omicron on transmissibility, because that has been the real game changer with how we're seeing Omicron spread throughout the world. And on the right is the appearance of Omicron in the United States. Shown in blue is the proportion of SARS-CoV-2 sequence that was Delta, and in the orange, the proportion of SARS-CoV-2 sequences, which was Omicron, and in green, other. And you can see over December, a rapid replacement of the dominant strain circulating in the US of Omicron, and almost identical images from every part of the world that has experienced an Omicron outbreak. So we know that Omicron has increased transmissibility by virtue of the graph on the right. However, some nice data performed in Denmark looking at the attack rate in hospitals in a household study clearly shows that the secondary attack rate of Omicron is about 50% higher than Delta. So the secondary attack rate in Danish households was 31% with Omicron versus 21% in Delta. There's no doubt that unvaccinated individuals have higher transmissibility compared with fully vaccinated individuals, and Omicron is 2 to 3 times more transmissible than Delta among vaccinated individuals. So the key issue that Omicron has evolved against is immune evasion, giving it the ability to also efficiently infect people who are vaccinated. Now, this shows you data on the viral load in the nase and oropharynx, and it's a really lovely study done on NBA players, actually, the National Basketball Association in the US. And this group have done a number of nice studies looking at the viral kinetics of SARS-CoV-2, initially with Wuhan and the Alpha strain, but now here with Omicron and Delta. So in these graphs, you can see on the left the peak viral concentration in the nose and oropharynx. You can see the proliferation time, and you can see the clearance time. And what you can see that compared with Delta in blue and Omicron in orange is that Omicron actually has a lower peak viral load and shorter clearance time than Delta. Now, it's unclear whether these characteristics are inherent to the variant itself or other population factors such as the number of vaccine doses, because this cohort had a mix of stages of where they were in vaccination. So high viral load on its own, as we knew with Delta, is not a reason for why Omicron is more infectious. Let's move now to disease severity. And this is actually quite a complex issue to tease out. At a population level, there's no doubt that Omicron has a lower disease severity, but I'm going to try and explain the complexity in achieving that conclusion. We do know that Omicron has some different features to Delta in its pathogenesis. It replicates faster in the bronchi and upper airways and less efficiently in the lung. And less lung replication may well be associated with reduced disease severity. And these studies have, of course, been performed in animals, in hamsters, and in mice, and also in vitro models. Now, initial data from England, Scotland, South Africa, and many other countries now looked at the risk of hospitalization in the Delta wave and then in the Omicron wave, so at a population level, and also clearly showed significantly fewer hospitalizations with Omicron compared with Delta. We have to understand whether there is differences in the intrinsic severity of Omicron compared to Delta. You need to look at studies that adjust the vaccination status, prior infection, age, and comorbidity. And in unvaccinated people, Omicron has got reduced severity or risk of hospitalisation compared to Delta, but probably about 25% lower risk. The vaccination status of the population is playing a key role in these large population studies, as well as the age group that Omicron is infecting. And that's what gives this sort of complexity in interpreting the data. And I think this is very nicely summarised on a lovely review article by Alex Siegel from South Africa, where he makes the point that we've got two issues here. On the left, Omicron is less pathogenic. So in populations with similar levels of pre-existing immunity, you can see there's fewer people with disease shown, or severe disease shown here in dark blue, compared to mild disease shown here in grey. And on the right, if Delta and Omicron had equal pathogenicity, but Omicron has increased capability to infect people with pre-existing immunity, you can see that the number of people with severe disease is smaller with Omicron because it's infecting vaccinated people compared to Delta, which is largely circulating in unvaccinated people. So these are quite complex concepts, but the take-home message that it is both. We're seeing reduced hospitalizations and deaths and ICU admissions from Omicron globally as a result of Omicron infecting populations that are largely vaccinated, but also there appears to be a difference in its tropism and pathogenicity. What about vaccine protection? Well, immunity against Omicron infection conferred by vaccination or previous infection is definitely less than with Delta. Omicron has evolved to evade vaccination and protection from prior infection. So Omicron neutralization following 2 mRNA vaccine doses, that's a laboratory way of assessing vaccine effectiveness, is lower compared with other variants. You just don't neutralize Omicron as efficiently as you do Delta and other variants after 2 vaccinations. People who received vaccine boosters or who've been previously infected and vaccinated have stronger protection against infection with Omicron. But even boosted, vaccine efficacy against symptomatic infection is 4 to 6-fold less with Omicron than against the wild-type virus. But important to know that vaccines remain effective at preventing hospitalisation and death, but with reduced efficiency with Omicron. And I'm going to go into some of those data in a bit more detail. Now, these are summarised 2 large population-based studies from the UK in the top panel and from the US in the bottom panel. And as you're now familiar with, assessing vaccine effectiveness on a number of parameters: symptomatic disease, hospitalisation, and death. And in the UK, there's been a mix of vaccines used: the AstraZeneca chimp adenovirus, the viral vector vaccine, and the 2 mRNA vaccines, Pfizer and Moderna. And if you just scan across the top row, you can see that the efficacy of those vaccines combined, and they obviously do vary with the viral vector and mRNA vaccines. 2 doses roughly gives you between 25 to 70% reduced chance of symptomatic disease. And you've got that very wide band because of these mix of vaccines that are being used. Move across, you can see that 20 to 25 weeks after the second dose, you begin to lose efficacy against protection from symptomatic disease, now drop down as low as 0 to 10%, again, heavily influenced by the mix of viral vector and mRNA in the UK. After the booster dose, or what's called 3 doses shortly after, you can see there's recovery of this vaccine effectiveness to 50 to 75%, but there is some drop 15 weeks after the booster dose. So the booster dose makes a very big difference in protection against symptomatic disease, and this does drop off, at least in these very early data, at 15 weeks. Let's look at hospitalisation in the UK data, and you can see that after 2 doses, a very good reduction in the risk of hospitalisation, 65 to 85%, depending on which vaccine is being used. 20 weeks after the second dose, that drops to 55 to 65% in the Omicron against Omicron. And at 3 doses, you get recovery of protection, and that's somewhat sustained out to 15 weeks after the 3rd dose. Finally, death, and this is only these estimates are in patients greater than the age of 50. You get 60% protection out to 20 weeks after the 2nd dose, and this bumps up to what was originally described in the clinical trials of 95%. So the take-home message from these really extraordinary data that the UK Health Security Agency are able to put together so quickly is that your efficacy against symptomatic disease with Omicron drops off very significantly after the 2nd dose. It's restored with the 3rd dose. Hospitalization also drops off, but there is still some protection maintained against hospitalization and death, but far better after the 3 doses, which is why there's this enormous global push to get booster doses. On the lower panel is the results from the CDC, just showing hospitalization, and the CDC data is in recipients of the 2 mRNA vaccines. You can see very good protection against hospitalization, 80% protection. This drops off at 25 weeks after the 2nd dose to 60%, exactly similar to what was described in the UK, and then recovery after the 3rd dose. And the other way that we can determine vaccine effectiveness, it's not perfect, but still very good correlation with both symptomatic disease and risk of hospitalization or severe disease, is neutralization activity. And these data come from the UK, from Oxford, and they show you the capacity to neutralize different strains of virus. On the left in green is Victoria. Actually, that strain is the Wuhan strain, which came from our institute in the Doherty, which was the first to isolate COVID-19 outside of China, here in Melbourne and the state of Victoria. So it's using the strain that we shared with the Oxford group. The middle panel in blue is the capacity to neutralize Delta, and the panel on the right, the capacity to neutralize Omicron. And you can see the capacity for neutralization, or the neutralization, you can see here, this is a reciprocal serum dilution here. So again, a higher number means easier to neutralize. And you can see here in the top panel, you can see the results after the 2nd vaccine, 28 days after the 2nd vaccine, and the 28 days after the 3rd vaccine. And you can see the capacity to neutralize against the original Wuhan strain remains very high. Now there is, and it increases over time. With Delta, you can see that it's now reduced capacity for neutralization because there's a drop in the reciprocal serum dilution, and there is recovery after the 3rd dose at 3-fold increase. And similarly with Omicron in the top panel, you can see that the reciprocal serum dilution is now further reduced with Omicron, saying it's more resistant to neutralization, but a fold increase of 3-fold after the 3rd booster. On the lower panel, you can see the relative impacts on neutralization after the 2nd dose, 28 days after the 2nd dose at 6 months, prior to the 3rd dose, and 3rd dose 28 days after the 3rd dose. If you just look over on the right on Omicron, you can see that greatly reduced capacity for neutralization due to the low reciprocal serum dilution, but this recovers with the 3rd dose at 28 days after the 3rd dose. So booster vaccines should be encouraged for protection against Omicron infection due to the very beneficial effect of boosting the neutralization titer by almost 60-fold against Omicron after the 3rd dose. And the other feature of vaccination that we know is important is the effect on adaptive immunity, or on the T-cell response, which is far less subject to variations in the spike protein, given that T-cells recognize different components of the virus in spike as well as other parts of the virus in people that have had prior infection. And in this study, which is still in preprint, the investigators looked at the effects of COVID-19 vaccine, the recipients of the COVID-19 vaccine, who are largely here on the left, those that received the Janssen vaccine, and on the right, the Pfizer mRNA vaccine. And they looked at the ability of T cells to recognize those viruses either 1 month or 8 months after their 2nd vaccination. And encouragingly, you can see that the frequency of T cells that are reactive, and this is expressed as the proportion of CD8 T cells that produce an important cytokine called interferon, that in fact 1 month after the Janssen vaccine, after the second dose of the Janssen vaccine, you can see that the proportion of T cells that produce interferon gamma against all three variants here, Wuhan as WA, Delta and Omicron, is very similar. This increases 8 months and maintained 8 months after the second vaccine, equivalent across the viruses. And on the right, you can see the proportion of T cells that produce interferon gamma in response to Wuhan and Omicron after the mRNA vaccine. So T cell recognition is retained. We think this provides protection against hospitalization. This is actually quite a difficult link to draw, but that is a good thing. And the virus has less capacity, it seems, to evade a T cell response. So if I just get back to the key points that we've discovered and that I've discussed, and I'll be able to answer many other questions as we go through the webinar. High transmissibility of Omicron is very clear. The reasons for that are not yet fully understood, but immune evasion plays a very significant role because suddenly Omicron has a much larger pool of people to infect when you're in communities with higher rates of vaccination and or high rates of past infection. Infection in people with prior vaccination and or infection is the main reason for why we see lower disease severity at a population level during the Omicron wave compared to the Delta wave. But there also are key differences in tropism of Omicron, less capacity to affect the lower respiratory tract that may well be contributing to reduced disease severity. Currently available vaccines have vastly reduced protection against Omicron infection after the 6 months after the second dose, but this is restored following a booster dose, and the durability of that protection is still being determined.
Wonderful. And thank you, Professor Lewin, for that excellent presentation. As you may imagine, we've had a number of questions come in from participants, and so we'll do our best to answer as many as we can in the time remaining. And so the first question comes to us, actually, Edward and Rochelle asked a very similar question about if Omicron produces less severe disease, why are we seeing hospitalizations and deaths go up?
Well, I think there's two reasons for that. And the first is the denominator. The number of people that Omicron can infect is vastly increased, even in a highly vaccinated population or in a population that's had prior disease. Omicron, even with reduced capacity to cause less severe disease in a vaccinated population, will still result in an increase in hospitalizations due to the dramatic increase in the denominator. The other key factor that's affecting hospitalizations and deaths, particularly in countries that don't have high vaccination rates, is the fact that Omicron still causes disease in unvaccinated people. And if you had to, there's varying data out there, but you had to line up the 4 variants of concern that we've experienced largely in high-income countries, the US, Australia, and others, Wuhan, Alpha, Delta, Omicron. Omicron slightly, in unvaccinated people, Omicron has reduced risk of severe disease compared to Delta, but it probably is more severe or similar to Alpha and certainly more severe than the Wuhan strain. There's no doubt that vaccination has broken that link between infections and hospitalizations. But once you have so many people infected, you're going to still see an increase in hospitalizations and deaths.
Thank you for that explanation, because I know that that's a question that comes up often with Omicron. Kind of similar to that infectious piece, we had a question from Karen who asked, what do we know about susceptibility to Omicron repeat infections? Are there any data on likelihood of being infected with Omicron and then having a repeat infection? I just wondered if you could speak to that.
I haven't seen a lot of data. There is some new data from the UK Health Agency. The UK Health Agency put out very frequent reports of national surveillance, and the proportion of cases that were reinfections is 6%. So that's the estimate, is that reinfection, what they've shown, reinfection is possible. The risk of reinfection is similar for Delta and Omicron, and it was a frequency of about 6%.
Wonderful. Thank you for sharing those data. We had a question from Jorge who asks, when do you think a fourth vaccine dose might be needed? So maybe if you could comment on studies or data that we have regarding a fourth dose following a 2-dose series with a booster and how that's being studied and what we know to date.
Yeah. So first of all, we do use fourth dose regimens in several countries, including Australia and I believe the US, in immunosuppressed people. So a primary dose in people with immunosuppression is 3 doses. The third dose, at least in Australia, is 2 months after the second dose, and then a recommendation for a fourth dose at 3 months after the third dose. So we do use 4-dose regimens in people who are immunosuppressed. The country that's investigated this at the greatest level is in Israel, where which has used entirely mRNA, and have looked at a fourth dose mRNA vaccine given to the population over the age of 65 and in healthcare workers. And that data hasn't been published. I haven't seen a preprint for that. There's been announcements showing that there was reduced risk of hospitalization in the elderly after the fourth dose. I'm not really sure how that will influence policy in many countries at the moment. In Australia, at least, I can't comment about the US. A fourth dose is not being recommended. We're waiting still for more data.
Great. And thank you for commenting on that as well, because again, it's a question that keeps coming up as those additional doses have been studied. And so to piggyback off of that fourth dose question, we had a question from Kaushik who asks what your thoughts are on the medical value of receiving an Omicron-specific vaccination, whether as one's initial vaccination or perhaps after receiving a primary series with one of our currently available vaccines.
Yeah, well, we don't have the results of those studies, but both Pfizer and Moderna have made Omicron-specific vaccines. The Omicron-specific vaccine for Moderna clinical trial has just opened, and the results of the Pfizer Omicron-specific booster vaccine hasn't yet been reported. There has, though, been a recent paper in the New England Journal of Medicine looking at other strain-specific vaccine, and from memory, this was from a Beta-Delta-specific vaccine. And the neutralization studies, and this is not vaccine efficacy or population-based or clinical readouts, but neutralization, interestingly, he looked at neutralization against variants, against a range of variants of concern. If you had a booster dose of the Wuhan strain or the vaccine that's licensed currently, or of the variant vaccine, and as it was a hybrid variant vaccine that recommended a range of epitopes of variants, and from memory it was Beta Delta. It didn't actually give you better neutralization against all the other variants compared to if you got boosted with the Wuhan strain, which was unexpected. Will that translate to differences in clinical protection? We don't know. And the answer of what will be the impact of an Omicron-specific vaccine in people, we are waiting to see those data. Of course, in this era, we will see the data on neutralization before any data on clinical efficacy. There are also animal studies, of course, that can tease this out. And I'm aware of animal studies that we'll likely see in the literature soon to see the impact of a variant vaccine, such as an Omicron variant vaccine, and then challenge with Omicron. So the animal studies, I think, will be very helpful, and they should be published quite soon.
Wonderful. Sounds like a lot more to come on that topic, and will probably evolve just like all of these vaccine questions have as we move through this Omicron wave. So kind of, again, still in the theme of vaccination, we had a question from Joshua who asked, is there a thought that at some point COVID-19 will require an annual vaccination for all those indicated for the vaccine?
Again, I don't think we know the answer to that. There is a lot of people hypothesizing that it will need to be an annual vaccine. I don't think we know the answer to that.
And sure, certainly too early to tell on some of these. Switching gears just a little bit, Brendan and Elizabeth both had a question about what is our current understanding of the risk of Omicron infections in pediatric patients? And is there any different data to share perhaps about the youngest patients that aren't yet indicated for vaccination?
The behaviour of Omicron in paediatric patients, to my knowledge, is very similar to what we're seeing in adult patients. So higher risk of infection, and that's clearly had major impacts in many countries with return to school. The protection from vaccination, certainly in the age group of greater than 5 or 12 to 15-year-olds, is similar from mRNA vaccines in paediatrics, is similar to the numbers that I've shown you in the relative vaccine effectiveness in adults and children with Omicron appears to be similar. Many places are reporting increased numbers of admissions of children in the Omicron era. But again, my understanding of the literature is that is, again, largely driven by this very large denominator of people at risk of infection, which is vastly increased with Omicron because it can infect vaccinated children. There's any data that the difference of multi-inflammatory system from COVID is, I've seen nothing showing that Omicron has a different risk for that. And the risk of hospitalization, of course, in children remains low as a result of either Omicron or Delta. It's just the pool of people who've infected kids that are so much bigger.
Sure, that makes a lot of sense. And thank you for your comments on our pediatric population. We had a question come in from Ulrich who asks, do we need new ways of applications of vaccines like nasal vaccines to help with protection against COVID infection?
Yeah, that's a very good question. And I didn't talk about any of the sort of next generation vaccines, which can be applied intranasally to get better mucosal immunity. I haven't talked at all about mix and matching vaccines and the durability of immunity and other vaccines that we're seeing now that are just moving into populations such as the protein vaccines or other totally different designs. I do think that repeated doses of a vaccine at 6-monthly intervals is not going to be sustainable and a very difficult strategy to implement. So many people are thinking very hard and testing others alternatives to just repeated, largely mRNA vaccine. And there is some early data, again, a nice study that was published in the New England Journal, and there are others showing that repeated mRNA vaccines compared to viral vector plus mRNA or mRNA plus viral vector, mixing the platform of vaccine may well give us different impacts on particularly T-cell immunity and potentially the durability of immunity. So I think we still need to be working very, very hard to identify different combinations of vaccines or new or next generation vaccines that give us more durable immunity to COVID-19 than what we currently have with repeated mRNA boosters.
Sure, that makes a lot of sense, and it's exciting to hear what's in the works, even as we've made so many advances so far to date. So switching gears a little bit, we've had a number of questions come in from a variety of participants asking about testing for COVID-19 infection during the Omicron era, and maybe if you could comment on testing discrepancies where perhaps someone tests negative on an at-home antigen test, but then tests positive on PCR test, maybe why one would test negative on one and positive on the other, and if there's any strategies for testing during the Omicron era.
Well, I think the first component of that is how do you tell whether someone's infected with Omicron or Delta? Wasn't the specific question that was asked. Well, I'll just start there. And of course, to answer that definitively, you need to do sequencing. And in an environment of millions of infections or thousands of infections, you can sequence vary. No country can keep up with the demand on sequencing. And on average, even in a country like Australia, where we have very, very good sequencing capabilities, we can only sequence maybe 1% to 2% of cases currently. So there is an easier way to determine if a patient has Omicron rather than Delta, and that is a PCR test. It's called an S gene target failure. It's a sort of a fancy second step on the PCR. Again, difficult in most countries to do this in real time. We only know that this, at least in Australia, it will take a day to get that answer, whether it was S gene target failure negative, which is Omicron, or whether the S gene was detected, which is Delta. And that's a pretty good test. It's not perfect, but it's a pretty good discriminatory test. But it's really used for population-based studies because you can't, again, do that on everyone and you can't do it in real time. But finally, to get to the issue of antigen test or PCR, the differences in sensitivity and specificity of antigen testing or PCR testing are the same for Omicron and Delta. Antigen tests are highly specific. They rarely give you a false positive, but there's a small percentage, 0.05% risk of false positives, and antigen testing will detect Omicron and Delta with similar efficiency. We know that antigen tests have a lower sensitivity than PCR, and that mainly is because you need a higher viral load to detect a positive in an antigen test. So they're very good when you have a higher viral load, which is in the 48 hours before becoming symptomatic or in the early phase of symptomatic disease. There's many different antigen tests and there's many different ways you can assess their sensitivity and specificity. But overall, and this is work that we did, but many others have done similar sorts of studies, is around 70% sensitivity. So, and that it misses 30% of people largely because of where you are in the stage of illness. And those discrepancies between a negative antigen test and a positive PCR test, which likely means you've got a viral load that's too low to be picked up on the antigen test, but can be picked up on PCR. Those sorts of discrepancies we see with Omicron and Delta. There's no reason that they would be different. Now, the NBA study, which I showed you earlier, which showed a lower peak viral load, would suggest that the sensitivity for antigen tests for Omicron may well be lower than for Delta. However, in an environment where you've got so many cases, the sort of criteria we use for diagnosis is a combination of both clinical presentation, exposure risk, and as well as confirmation with an antigen test. And at the moment, a key issue globally is reduced access to antigen testing. So we're really just refining the most cost-effective algorithm for testing. And I think every country is struggling with that at the moment.
Sure. And in that same vein of, what's most cost effective and what's available to people, what are the recommendations or what are your thoughts on patients needing a negative test, whether PCR or antigen, prior to interacting with others again?
I probably won't go into that in detail because the policies vary so much around the world. And even in a country like Australia, the policies change very, very rapidly. And if I could just make one high level comment, the overall bar of isolation and quarantine and stringency for both of those interventions has reduced dramatically, certainly in a country like Australia where we used to chase down every single case because of the pragmatic issues of dealing with lots of cases, the real risk. Every country has a different public health policy, and most countries have a policy at the moment of protecting their hospital system and reducing hospitalization and death. So the most confusing thing for patients and also for doctors is that these policies keep changing, but they're changing because of a changing overall strategy around public health. So exit tests to prove that you're negative, I think those policies vary greatly week to week in Australia. So I think there's going to be a lot of variation globally. So I'd probably best I don't comment on that.
Sure. No problem at all. David asked a question about monoclonal antibodies. So maybe if we switch off of the testing topic for a moment. And his question is if you could comment on pre-exposure prophylaxis with an agent like texagevimab and silgavimab, the combination that's authorized for pre-exposure prophylaxis, and how might use of that pre-exposure monoclonal antibody maybe affect needs for a fourth vaccination dose in immunocompromised patients.
Yeah, I think David raises a good point of other tools that can be used to protect particularly vulnerable populations or immunosuppressed people or elderly people who might have had a reduced or suboptimal response to 3 or even 4 vaccines. So the way we would do that for pre-exposure prophylaxis is very similar in concept to how we use pre-exposure prophylaxis in HIV. We use an antiviral drug that's on board and prevents progression to symptomatic COVID or in HIV infection. And antibodies, particularly the antibodies asked about with AstraZeneca, have been shown to play a role in pre-exposure prophylaxis. The issue is its efficacy in Omicron. So Omicron, because of its resistance to neutralisation, as I showed you post-vaccination, also has significantly reduced neutralisation for many of the commercial antibodies. And the only antibody that has retained sensitivity to Omicron is sotrovimab. So in the Omicron era, the toolbox of antibodies is vastly reduced. Antivirals, oral antivirals, which are now coming on board, molnupiravir, Paxlovid, and there will be others, haven't yet been evaluated in the pre-exposure or post-exposure prophylaxis, but you'd imagine that oral antivirals may well play a role. So how countries use antibodies or eventually antivirals in pre or post-exposure prophylaxis is still being determined. In Australia, we would not use an intervention like that at the moment. There's a whole lot of factors to be weighed up, particularly cost effectiveness and the number needed to treat to prevent infection. And at the moment, with the costs of antibodies as well as antivirals, I would say that this is not going to be a cost-effective intervention, but we need to work through those issues. And also, antivirals over time may well become cheaper.
Thank you very much to Professor Lewin, and thank you to our listeners for joining in. As a reminder, to view the full COVID-19 Resource Center on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.